Emergency coming 5 minutes by London ambulance service.
So what do we know? So there's period arrest, 50, high potency of bread and carbo.
56-year-old Edward, called about 2 o'clock, said he had central chest pain. He was in peri-arrest, bradycardic, around sort of 30 to 50.
56-year-old city worker Eddie is suffering a major heart attack.
Oh, hello. All right, Edward, you're in hospital.
After calling 999, Eddie collapsed at home alone. His heart is severely unstable and could stop at any time.
It's all right, need some extra pin, please. Yeah, quick. What do you need? Some pin. Blood pressure 125.
What's the last heart rate?
It's 35.
Okay, perfect.
Yeah, aspirin's in.
Hammersmith is one of the UK's foremost heart attack centres, or HACs. Eddie will receive acute treatment only available in specialist hospitals.
My facts, please.
The HACs are like a specialised A&E just for the heart.
1, 2, 3.
London Ambulance bring us more and more patients, so probably double what we would have seen 5 years ago when we first started. Anna, have you got an ECG? Where's the ECG? Oh dear, the ECG is showing that he's having a big heart attack. So the team is going to intubate because he's so restless. He's got no forward output, really. Next stage, which is to get into his arteries and take a picture, find a blockage, fix the blockage. It's just making sure that he doesn't have a cardiac arrest before we get to that point. Pressure line on, please. The faster you are, the more muscle you save. And it's important when someone's really sick to get that artery open as fast as you can. So we've got to get beyond this tricky leg.
A catheter wire is inserted through Eddie's groin into his heart. Balloons and small mesh tubes called stents will then unblock his arteries, a procedure called angioplasty.
It's got to be a big right.
It must be a huge right. OK, we're in now. Yeah, there's a huge, great big clot that's just blown downstream. We'll see if we can't suck it out. OK.
Is he stable now, or is time still stable?
No, I wouldn't call him stable. He's on blobs of adrenaline. So let's just see if we've got a clot here. I don't think there's any big clot there. We're going to go back in again. We need to get rid of any clot that's sitting in this line. No point in taking the clot out of the coronary artery and then blowing it into his brain. That would be bad, wouldn't it? So, now that may have trapped something because that's not coming back. It's opened up. This man had, I'm amazed he's alive, he had 2 blocked arteries. So 40% of patients have 2 ruptured clots, but not 2 ruptured clots causing complete blockages, that's to say. OK, good.
The Heart Attack Centre is one of 7 set up in London within the last 10 years to consolidate specialist skills and resources.
He decided he wanted to live.
Since they were established, survival rates in the capital for the most serious heart attacks have doubled.
OK, let's see what we have. So this is a nice story, yes? Potentially.
I'm very clear that today he was dead if he hadn't ended up with us and had gone to a smaller hospital where they didn't have a cath lab. Had he had a cardiac arrest in an A&E department without a cath lab facility, he would never have stabilised to come over to us to open up his arteries. There's no debate about it. He would be dead.
And where are you off to now?
I'm into the next lab, so we've just started another hot case, not quite as hot as him. It's a gentleman who's in his 80s who's presented with a heart attack.
Any change from this morning here?
It's 24 hours since Eddie arrived at the HAC, suffering a major heart attack.
This came as quite a surprise. I would have expected there to be a feeling of panic and something like that. And for some reason, it was like, I just hope that they get here with that ambulance quickly. But if not, then this could be it. That's all I felt. I hadn't really thought about it that hard until then. So it's quite heavy. But I'm here.
He's done pretty well, actually. He's come off the ventilator. He's come off all the drugs that were supporting the heart yesterday. He said for the extreme types of heart attacks that we see, that is a speedy recovery. And hopefully, he'll be back at work within a few weeks. Hello, sir.
Hello.
Right, how are you feeling compared to this morning? Does anything not make sense to you? Because you've been through a lot in the last 24 hours.
No.
It has been literally 24 hours this time yesterday.
Yes, indeed. No, people have explained it very well.
OK. Yeah, your heart tracings are good, your monitoring, your blood pressure and everything's been good. So I think we can literally unhook you from all of this, make the next step and get you to the ward. And you'll find as days go by, the heart gets stronger and stronger, and that should make you feel better as...
Yeah.
Cool.
Okay.
Great. Bye-bye.
As a frontline service for the heart, the hack is incredibly successful. London is pretty well served. The rest of the country is following suit. These heart attack centres mean that there's a concentration of skills, a concentration of staff. These patients stay in the hospital for less days, and therefore not only does their life get saved, it's also cost effective.
Okay, sir. Lock the door now.
Every division in the Trust must make significant cost savings to hit efficiency targets set by the government.
Morning.
It's the job of General Manager Steve Hart to oversee the Trust's cost-saving plan for their cardiac services, including the hack.
Firstly, sort of good news story for the team. So last year, 16-17, challenged to deliver a £2.3 million cost improvement programme. We actually achieved £2.6 million, so surpassed what we were expected to do. What that doesn't mean is that 17-18 is going to get any easier, unfortunately. So last year, our challenge was £2.3 million. This year, we've got a new challenge of £3 million. The plan is basically for us to either deliver more activity to a higher quality for the same money, or to deliver the same activity to a better quality for less money. I'm going to go through the plans now and sort of let's have the honest discussion around when are these likely to start. Be mindful of the fact that at some stage we may need to close beds unless we expand the service.
Every year we're asked to make more and more savings, and it gets to a point where actually there is no more meat on the bone. What about 7-day working then? Where's that rolling out?
So I think 7-day working is getting discussed as part of the chest pain pathway discussions. I'm hoping we don't need to do it, and I'm conscious that we will be calling on the same group of staff that have already said we don't really like working Saturdays and Sundays.
7-day working in principle is an excellent idea. It doesn't matter what day or time you're admitted, you should get the same treatment. However, we cannot implement something when we don't have the infrastructure to do it.
Is there a demand for a 6th cath lab to support growth in private patient activity?
I'd just like it to be minuted that I am really, really nervous about this 6th cath lab that seems to be rolling on. It is impossible to have more cath labs than we have CCU beds.
And it
cannot happen.
So at the minute, I think this is the bed discussion is very much a pipeline discussion. What you need to do is see it in the business case, which is what I intend to enable you to see.
Charing Cross Hospital is the Trust's specialist centre for neurosurgery and the treatment of brain tumours.
I'm off in to see my oncologist. She's asked me to come in quite urgently just to have a chat about my recent MRI scan.
28-year-old Ben had a brain tumour removed 4 years ago.
I've been here a lot because this is where I was operated on to have my brain tumour taken out, and then also that to have my follow-up radiotherapy and chemo.
Since his operation, he's been monitored by consultant clinical oncologist Alison Faulkner.
He's been having scans every 6 months since he finished treatment. Over the last year, there's been a progressive change in his scans.
Dr. Faulkner's called me in, but I don't think it's an official appointment. She just said to come in for 11:30.
We've got the grade 3 brain tumours, which Ben has. With these tumours, half the patients have died in 5 years. And it's 4 years since surgery.
Hello. Hi, Ben.
Hi, how are you?
Good.
Nice to meet you. Oh, so I've heard your name a lot.
Kevin O'Neill.
Yeah.
Did we meet before, or was it?
I don't think I've ever actually met you. I just always hear Kevin O'Neill.
Do you?
I think you're famous, basically.
So we've been discussing you, now we're a big team, so we work all together.
OK.
So how have you been? Have you been
I've been fine, yeah. I've had absolutely no symptoms from my brain.
No seizures?
No seizures since the op.
There's always a chance that things could change.
Yeah, which I've always been aware of, yeah.
I think if you look back, you can see a little rim that looks like maybe a residual bit of tumour that looks like it's been very well behaved. But in the last scan, it just part of it looks a little bit bigger. That would warrant us going in to remove that bit that's growing and potentially threatening you. So.
OK, so you're saying that you feel I should have another operation?
Well, we all feel that, you know, that there's a risk of leaving you alone. And the risk of treating you is less than the risk of leaving you alone.
From my understanding, the tumour that I have had, blah, 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 it was slow growing.
Relative to the fast ones, unfortunately, there's always a spectrum. So there's barely growing, which are what we call benign, 1, 2. The grade 3, which is what you had, means that you can't just sit and watch it and, you know, observe it lifelong.
Okay.
Has to come out, have the chemotherapy, have the radiotherapy, as you did. Yeah. And the grade 4 are the much more aggressive ones.
In terms of timings, what are your thoughts then on when would it need to?
Probably in the next few weeks, 2 or 3 weeks, we'd need to set it up. And have you got plans?
Well, yeah, I've always got plans. I'm really busy, but we'd have to work around those.
No, it's not going to be tomorrow.
And so
we've seen it grow. There's no point just sitting on it and watching it. We need to do something about it. Does that make sense?
Yeah, it's making sense. It's just a pain in the ass, basically.
It's a tricky balance.
Thanks very much. It's just a lot of stress. It's just annoying, isn't it?
It is annoying.
Yeah, it's annoying. It's just.
It's nothing to what I said when I saw the email. It really isn't fair.
No, it's not fair, but it's happening, so get on with it, I guess.
All right, so.
Yeah. Great.
Why don't you get out into the sunshine?
Yeah, exactly. Oh, it's fine. OK.
All right.
Yeah, thank you very much.
Oh.
I know, what the hell? It was going to happen at some point, I think. Oh. Thank you.
Right.
Yep.
Take care. See you soon.
Oh, thank you.
Was it always going to come back?
No. We always hope. There are patients whose tumours don't come back. He's been the unlucky one.
So this is Ben's story, basically. So he had a tumour way back in 2012. This is my colleague who did a very good resection and got a lot of this out. You can see a big resection cavity here, but over the last few years, there's been something that's been growing anteriorly. If we give it enough time to regrow, it can transform into something higher grade that will threaten him.
It's very, very frustrating treating brain tumour patients like Ben, where they've had good surgery and, you know, his tumours come back. The biggest problem with brain tumours is they have such poor survival rates. Many of them are very aggressive. For that reason, cause the greatest reduction of life expectancy compared to any other cancer, because they can affect any one of us at any age. Most of them are fatal, and under the age of 40, they're the greatest cancer killer. You know, you want to solve this problem, and you want to make things better. That's what drives us on to try and research and develop and design new technologies, new treatments.
Kevin and his team are at the forefront of using new technology to understand more about brain tumours like Ben's.
I didn't know exactly how my story would pan out, but I had a grade 3 brain tumour, which had been treated, but there is the history that it does come back. But the thing is, like, I've just got on with my life, and I've enjoyed things, and I've been, you know, living my life and getting on with it. And then it has happened, and now I just need to do it again. It hasn't really hit home yet, but I know that tomorrow it's like surgery time.
28-year-old Ben is at the neurosurgery centre in Charing Cross for his brain tumour operation.
When this first happened to me, I was 24. I moved down here to train in musical theatre, which I'd worked in until this happened 4 years ago. Last time, I was having visual problems, dizzy spells, a couple of seizures, which I didn't realise were seizures, basically blurred vision. So I was rushed to A&E and they found the mass from a MRI scan. Then it was found to be grade 3. I lost my left peripheral vision. It was all pretty horrific. Giving up dancing and going to dancing auditions was hard because that was my career path. And I think I went through a sort of grieving process. And now that it's happening again, it's all a bit... It's like going back to 4 years ago, like history repeating. It's like bringing everything back.
To prepare for the operation, the team creates a 3D map of Ben's brain.
Will it be okay with these things? Yeah, that's what they're going for. Okay, but yeah.
This will help Kevin pinpoint Ben's tumour during the surgery.
These days, as opposed to this previous surgery, which was 4 years ago, we now have more tools in the box. So we now have quite useful intraoperative imaging, which tells us where things are, despite things moving around. But we're also developing new tools.
Ben has consented for his operation to be part of a pioneering research programme, which aims to change the way cancer is diagnosed and treated.
Do you need sort of people to sort of, you know, guinea pig this?
We don't want anybody to be a guinea pig. None of us wants to be a guinea pig, but I think we are now starting to make advances. You know, with innovations, it's going to open up a whole new world of research and potential treatment options for these patients.
It's literally signing your life away, isn't it? No.
Good. All right, well, we'll see you soon.
Oh, okay, yeah. Thank you very much. Hello.
How are you doing then?
Yeah.
I had a little bit of a shave there. Okay. Did you do that, or did we do that?
No, I didn't do that.
Oh, okay. Well, look, you happy about tomorrow?
Tomorrow, yes.
So what we want to do is try and get you back to a point where you've got very little or no discernible tune on the imaging.
My main concern is my visual fields, and I know you can't promise that they won't be affected.
There is a small chance that that could be affected. How are your visual fields?
So I've got no left peripheral from the last operation.
Yeah.
And a tiny bit hindered in the right.
Look me straight in the left eye
Yeah.
and just tell me when you can see my finger coming, and I'll kind of do the same. Can you see it coming in? Tell me.
Yeah, now.
Now, okay. I can see this way out here. You can't see it until we get to the midline. You've got some deficit up there, but it's mainly the lower quadrant, isn't it, on that left?
Yeah.
Right.
So
we can't guarantee. I mean, the vicinity that it's in is close to where the connections from the eyeball to where the brain perceives vision. Those radiations, it's been, they're going around that and been stretched by that, and they have been interfered with. Obviously, every surgery we do has a certain risk to it.
I don't know, but I feel like I'm healthy enough to walk.
I'm going in for this major surgery, but I feel fine, and it's really weird. Like last time, I was having seizures and a few blackouts, and I was on high medication, so I was feeling like shit. But this time, I'm feeling really fine, so it doesn't feel right for me to be having surgery this morning.
It's the day of Ben's operation to remove his brain tumour.
Can we come up or...? No? OK, all right.
His family is here from Huddersfield to support him.
See you in a bit.
It's just mixed emotions, you know, trying to be positive for him and reassure him and everything, but it's a bit surreal. You just kind of...
What?
I don't know, you can't imagine it. I couldn't imagine it for myself.
Yeah. What you want is it to be you.
Yeah.
You want it to be you, not him. And that's the feeling I had. It should have been me, not him.
Now we're here today and he's having it done, he's going through it all again, and it's just...
Well, he's going to come through it and he's going to be fine. He's got loads of years ahead of him. He's still got a lot to do in life. Still got aims.
Oh, God, yeah, always, yeah.
We've created a three-dimensional image volume of Ben. You can recognise that's Ben. These are the reference points, these little markers we put on his head, which we use as reference points to correlate this virtual image to the real Ben. You can peel away the surface and look at all the blood vessels that you need to avoid. Years ago, without this sort of equipment, it would be a lot harder. I remember the days of putting a CT scan up and marking on those lines where the tumour was on the scout image to see where we'd make our craniotomy. You just hold it up and stand back and look at the image on the wall. Now look where we are now. You can see I'm pointing to this fiducial. So that machine is telling me where I'm pointing. It even shows you my probe, look. Beautiful.
During the operation, Ben could lose more of his peripheral vision. There's also a risk of loss of sensation in his left side and paralysis.
It's really that bit that we want to take out there.
Ultrasound probes will carry out live brain imaging, guiding Kevin along the 3D map of Ben's brain, helping him safely remove as much tumour as possible.
On the left-hand screen, you see the grey of the MRI, and then on the ultrasound, you can see that bright signal in the cavity. Very clear cavity. I can actually see it, and there's tumour there, look. Yeah. You can actually see it with your naked eye. Amazing. OK, so we've got to try and get that out.
That's Ben, Emma, and that's Molly. Yeah, happy-go-lucky, yeah, always wanted sort of...
bossy towards the
yeah,
other
bossy. Always liked to have people around him.
His main thing was musical theatre.
Yeah.
He wanted to be in the West End. Yeah, he wanted to be there.
That was his dream.
Yeah.
I just hope from today that they can do what they need to do to get all the cancer out, all the tumour, so he can move on then with his life.
Ben has agreed to be part of a research programme testing a new diagnostic tool, the iKnife, which is being pioneered at Imperial.
This is the iKnife, so you take tissue, you turn it on, and it buzzes the tissue, coagulates it. You get some smoke being produced, which then gets sucked up into this tube. And that tube then goes into that machine. It tells you what the molecular makeup of that vapour is. I'm going to get some iKnife samples here, and then at the boundary. So shall I take a iKnife sample?
As the iKnife heats and cuts the tissue, it generates so-called surgical smoke.
It's basically like a sniffer knife. It's smelling the vapour coming off of the tumour. Got something?
Okay, good. Healthy tissue gives off a different molecular signature to cancerous tissue. The iKnife analyses the smoke and transfers the data to its computer.
We've got a very, very early model, which is not, we don't have a huge amount of data. Usually, if you were going to have a robust database, you would want thousands, even tens of thousands of bits of information to build it on. So it's very early days.
The iKnife can already identify the margin between healthy tissue and a number of different cancers, but it's still in the training phase for brain tumours.
The thing about this is that it's bringing the lab into surgery, giving us information very quickly. Maybe possible in the future we'll have treatments that we can give locally. As we're operating, rather than then have to be closed up and then wait for post-op chemotherapy, radiotherapy, we can actually start giving treatments instantly alongside surgery. Perhaps, if we're lucky, give us some answers to a potential cure. Let's see. So now you can see the tumour, and I'm just now pulling it away from more normal-looking brain. But it looks kind of greyish and potentially a little bit more aggressive than it perhaps was. So what I'm going to do is resect now. Tumour.
Ben's tumour is sent to a lab where pathologists will determine if it's more aggressive than his original cancer. It'll be 2 weeks before he gets the results.
That tumour that was down there is all gone. Yeah? If this turns out to be slightly more aggressive, then it's the best thing we could have done. Right. Good. Hi there.
Hello.
How you doing? You okay?
Yeah.
Relief it's all over. Yeah. Feeling okay?
I'm just relieved that my vision is here.
Good. Still got your vision, yeah.
I was very worried that I would wake up with no vision or less vision, or
Yeah.
I just had nightmares that I would work it up to, or not wake up, or have blackness, or
Yeah.
If I'm honest.
It's a big relief,
Sorry,
isn't it?
I don't really know what to say.
Don't worry, you're going to have a bad headache because we took some pressure off, so it's going to be like the worst hangover you've had. No,
Very difficult.
Of course it would, no.
To cope with.
No, you've done really well. You know, you could almost see the tumour with the naked eye, but we just confirmed it with everything, and it all correlated, and it's all gone, so...
Oh,
yeah.
what?
Yeah, it's all
You've
good.
got it all out?
Yeah, pretty much.
Oh, wow.
Yeah. Very happy. Okay, so you can relax now.
Thank you.
You can relax.
Thank you very much.
Okay.
Wow.
All right.
Thank you. Thank you very, 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 very much.
No problem. I'll see you later.
If anyone wants to ask what relief feels like, get into my body now.
Okay, you're gonna have to go back to the next operation now.
Thank you. Good luck.
See you.
Thank
Cheers.
you. Well
Bye.
done. Thank you.
He's had all that technology thrown at him, and he's come out the other side really well. So he will benefit, but the real benefit will come for patients in the future when that technology is really well developed and validated. But without patients like Ben, who are willing to donate their tumour for analysis, we're not going to make those steps forward.
Thank you.